Hey everybody, it's Kevin and Thea. Really excited to jump into this really exciting episode of the Remote Care Services Show. And I'm going to hit the reel for us, and then we will jump right into it with Thea. All right, everybody. Today's episode is another classic clash of clinic collaboration versus service agreement. We'll go into what that means a little bit deeper with Thea here, but really thinking about what do? You want to get into remote care services. How do you arrange these with a clinic or collaborating provider? And what are your options? What are the difficulties? Thea, educate us.
All right. Thanks, Kevin. As always, trying to bring relevant information for those looking to get started or interested in what this really looks like. Now, I take the operation to the physician side. So looking at pharmacists in a clinic or in an inpatient hospital setting have more relationships built with a lot of the practitioners that they know, like, and trust. As the retail pharmacists have a little different angle, right? They're getting the patients and understanding from the prescription level what the providers are doing and that kind of stuff. So their relationship is a little bit less cohesive, maybe just more of a service line. Doctor gives patient prescription comes to the pharmacy, we fill it, and the patient's on their way, and what that interaction from the provider really looks like. So I'm going to take it back and say, okay, all pharmacists are the same. We're talking how to come up to a physician and say you want to offer these services. And there's languages that I have found over the 4 years of doing this that work a little bit better than other languages when we're talking about how to get paid for the service, right? So most of the people that I know and what I've done is always been a consultant for the physician offices. So that's running off of a 1099 versus as a W-2 or an employee of the office. So that allows me some flexibility because I don't necessarily want to be in the offices at all. I want to be remote and location independent for my kids' sake and my balance of what I'm trying to navigate at home and work. So really looking at how to get that contract signed as a consultant, not wanting to be a W-2 employee. And I will say that the one benefit of that is that there's no limit to your salary. It's patient volume, right? That's the limiting factor there. So whether you're more comfortable, though, with doing a W-2, that's perfectly fine as well. Because I know, like, I started as a consultant, but then the hospital found me, and then I'm a W-2 as an entrepreneur and an entrepreneur. So it kind of was balanced for me, but I still lean more towards that 1099 opportunity because there's no cap on the opportunity. And when I look at the service agreement of what this looks like, or collaboration of the contract, I lean more towards a service agreement because I feel pharmacists in general understand what those service agreements could look like from a legal standpoint, because we all have service agreements, right? Whether you're a pharmacy and have POS services or that service agreement from your cell phone to your internet to everything, we all know service agreements, right? When we look at what a collaboration looks like, then we're like, oh my gosh, is that clinical? What am I supposed to do with that? Like, do I know anything about that? Like, these are the questions that I get, is like, okay, calm down. Wait a second. Isn't a service agreement the same as a collaboration? Because you're offering a service to the provider. Okay, it is more clinical than the telephone service. I get it. But at the end of the day, it's saying, I have this service that I would like to offer you to your patients for us to work together. Now, that's where collaboration comes in, right? People think, oh, I got to collaborate and be on a multidisciplinary team with the person or with the physician. And from us on the inside of hospital settings, we're used to that, right? We're used to protocols and procedures and how to do it all for the standard operating procedures, which allows some flexibility for how pharmacists can act as an in-house or in-hospital pharmacist if you have clinical rounds and clinical duties. But when we look at the outside, I've really found that collaborations make the physicians clam up. Like, they're like, I don't know you from anyone. You're walking into my office, bringing me lunch. Great, thank you. But you want me to trust you. Well, who are you? Like, I don't even know you. I don't even know how you practice. I don't know that what you're telling me is all true. So how do we present this in a little bit better of a fashion to the providers? Because what I have found is that presenting it as a service agreement is less, I don't want to say intimidating for the providers, but less offensive. Like,
Mm-hmm.
oh, you need this collaboration because you're not doing your job and you're a terrible doctor and all that stuff. That all comes with the insinuation of a collaboration, like they're missing something from the physician side.
Yep.
And so the physicians get upset because you're asking to work with their patients with a collaboration. And to them, most physicians know collaborations from hospital settings. So they're looking at, oh, you just want to come in and change my medications. You want to change my regimens. You want to, monkey with the treatment options for these patients because you're watching their readings and I won't even know. And what's that going to look like? And so with the service agreement, it takes that maybe assumption from the physician off the paper. And really, go ahead.
No, I was just going to ask you, Thea, like when you separated those, I think really well, but when it comes to the clinical components that you're kind of mentioning there with, you're going to change the medications, you're going to ask me to monitor more things, et cetera, et cetera. When I think of clinical collaboration and when I'm thinking about, hey, let's set this up so that I can change someone's blood pressure medications and put in a collaborative practice agreement, just because we have a service agreement in place does not take away from the fact that we can still implement a CPA, correct?
Yes. And I found that you don't do that upon walking in the door and saying, I'm a new provider, I'm new pharmacy with this great service that you need. Yes, they need it. There's lots of reasons why they need it. You probably have patients that show you they need it from a pharmacy standpoint. So, but the trust factor is where I have really found if you can build trust in the first 10, 20 patients with the provider, then you get to see how they're practicing. Then you get to see how their office runs, because a lot of the complaints or maybe accolades I hear from the patients that go either way is about the office staff, not even about the physician. So like getting an understanding of how the office is running and who really is the action makers at the office and getting that through to, okay, I know I need to go to the office manager for this and this nurse for that and the physician for this. Once you get that relationship built, you'll get an understanding of where a collaborative practice agreement with protocols that allow you to change things go. But until that trust really happens, unless Dr. Jones has been in my life for the last, 30 years and I know them and I like them and we practice well together while I was at the hospital and retail. He's always open to the questions and answers. If your relationship is like that, maybe a collaboration would be great from a collaborative practice agreement. But to get the process going, I hands down would recommend a service agreement as opposed to what we call a collaboration because of the insinuation of I'm here to change what you're doing or augment. The service agreement just says, this is the service. I'm going to give you this data and I'll make a recommendation, but I'm not changing anything versus the collaboration. So I really feel like a lot of folks get tied up in what to call the contract. And I think we need to take it back to the basics and just call it a service agreement. I have a service for pharmacy consulting programs that are a great option for your physician as well as, for the patients at large.
So with your stepwise process, you can really layer the benefit, right? Instead of going in and saying, guess what, provider, like I'm going to give you all of these things, plus take off all of your pain, plus overwhelm you with this massive pitch. I'm going to make it really easy for you and add on a service agreement so we can take advantage of some of these CMS programs to benefit your patients. And then from there, you have the physician go, this is more work because now Thea is recognizing that I wasn't treating my hypertensive patients as well. And now I've got to change their prescriptions and do all this extra work. Guess what? Thea steps in, superhero cape on, and says, if you want, I can do that for you. Like all we have to do is establish a CPA. And I love that. Like you don't have to bludgeon them with like, these things are going to come up. You can just let them naturally occur. And then you can adjust them and add on additional services.
Right. And that's what it ends up being is the next year's contract has a protocol as Exhibit A or Exhibit B. And, you sign for that year and you move along. It's the service agreement for year over year. And as I went, I've always added services every year because the need from the office standpoint, especially through COVID, was like, oh my gosh, Thea, I need somebody to do this for me. Can you manage doing that? And I'm like, yeah, I'll do that. We'll put it on the contract for the next year, what that service agreement looks like. And then that way I'm constantly adding value, which then as the monies go up for these programs or down, unfortunately, sometimes, as we look at those, they don't hesitate to make sure I'm getting paid. As that 1099 person, you're kind of the last person to be seen in the office because let's be honest, never seen in the office because I don't go there. And so am I the last person to get paid? I don't know. Am I? If I'm constantly adding value and over delivering on what I can do by setting the expectation as only service, not clinical, collaboration through protocols and procedures, I don't need to go there yet. It will naturally progress to that if you're doing and showing up for your patients.
Yeah, no, I think that's so. One other thing I was going to ask you, Thea, is really tied into the money equation, right? The financial element of it is the difference between the service agreement for you to be able to charge for, and service agreements, the way you've set them up, and you and I have talked before, is really on a per patient basis, right? So we're taking care of these patients. We're mimicking what we're seeing inside of CMS for billing guides, and then taking a percentage of that, saying this will be my commission, basically, for providing these services.
My service fee for that code, not a revenue share. Medicare does not like revenue share. They like a fee schedule for each code that you're offering. So that's always Exhibit A for me. Exhibit B moves on out the line for different hours that I work and different collaborations down the road, that kind of stuff. But Exhibit A is always my fee schedule based on codes. And that lines out, am I doing a good enough job? Are they going to pay me? No. I issue that code sheet that they need to bill. I issue the invoice based on that fee schedule and move along month over month.
That's perfect. So instead of the last nugget I'll ask for you before we say goodbye until the next time is when we're setting up these service agreements, and as you mentioned, the fee schedule, we've talked about one kind of interesting conundrum, and that's, does Thea get paid upon completion of task or upon completion of bill?
That depends on the service, right? Agreement. It depends on the agreement that you have written. In my contracts, I've always, because we're rural America, we're Northwest Pennsylvania, there's nothing here, armpit of America. And so we always have to be like cautionary because these offices are struggling, right? To stay afloat throughout COVID and all of the stuff. Having enough employees to keep the doors open, blah, blah, blah. So, what I've always done is put out an invoice for a 30-day return on that invoice. And then that way, yes, I have to wait 30 days, but they will have already gotten the money because Medicare's usually about 21 days, 14 to 21 days on return of that receipt of those codes. And then that gives them also time to bill off the secondary insurance, which picks up the most of the other portion of the fee for the patient. So at the 30-day mark, they will have gotten the majority of their money for those codes. So I'm not asking for them to bankroll my invoice on these supposed codes. No, I let them sit with it for 30 days and then ask for that. And most of the offices are really good with getting that money back to me because they're starting to see it come into their bank account and they know that that's where I'm going to get paid from. And it's not an added expense to the office. Everything I do is based on codes. I don't ask for them for any other money other than that. And then that way, at the end of the day, it's one check to me.
You just ease your entire sales process because cash flow is king, right?
Yes.
In any setting, rural America or urban, like they want to know that the cash will be there so that they can pay you, and giving them that kind of window is massively helpful. Fantastic. Yeah. So our next conversation, Thea and I will punch it out there for you guys to be able to see. I hope this helped kind of ease some of the pain and burden of how do I even start? How do I even look at this process to be able to get in first? Now that you know the benefits having a service agreement on your side and all the simplicities it adds to the office and your provider relationship initially, I hope that really helps out. But if you want to learn more, I know you do. Head on over to RPH Ally and to Thea's channel for remote care services. Get all kinds of inside tips on kind of what to do, what processes Thea is taking on. And if you want to do it yourself and become the level of expert that Thea is to do this in your community, at your independent pharmacy, or as an individual pharmacy practitioner, join Thea's course and be able to jump far into all of those exciting things. Thea, always good to see you. We will see everybody next time.
Next week. Take care.